Thank you for your interest in our project, Predicting Cardiovascular Risk in Pregnancy Through Machine Learning. Have you ever wished you'd have known earlier that you'd seen the signs that a pregnant patient would develop a cardiovascular condition or experience a critical cardiovascular event? We are seeking those answers through machine learning technology. This study was conducted in collaboration by MedStar Health Research Institute, Georgetown University, and Invariant Incorporated through supplemental funding as part of the Georgetown Howard University's Center for Clinical and Translational Science. Our project leaders were Dr. Nawar Shara and Rahman Dempers. For our study, patient electronic health data were sourced from MedStar Health, machine learning and technical expertise were provided by Invariant, and clinical expertise and insight were provided by representatives of Georgetown University, MedStar Health, and Invariant. To give some background, in the past several years, maternal morbidity and mortality have become a hot topic. In the U.S., rates are higher than any other developed nation and continue to trend upward. 1 in 4 maternal deaths in the U.S. are a result of cardiovascular disease, and an estimated 68.2% of those are preventable. It has been found that earlier diagnosis and intervention alone could prevent 25% of maternal deaths related to cardiovascular disease. Going into this study, we wanted to know, 1, if electronic health records could be aggregated and organized in a way to make the data actionable. 2, if machine learning could be deployed to analyze that data and detect signs of risk related to cardiovascular disease or events during pregnancy. And 3, if due to the data being in one place, machine learning would detect signs of risk in a patient earlier than indicated in the electronic health record. For these reasons, the aim of our study was to leverage machine learning to evaluate patient electronic health record data for trends and changes to predict the risk of cardiovascular complications during the peripartum period. This was a retrospective study to assess the performance of machine learning technologies using the electronic health records of just over 32,000 pregnant patients. The machine learning tool used was called Healthy Outcomes for All Pregnancy Experiences Cardiovascular Risk Assessment Technology, also known as HOPE-CAT. HOPE-CAT is an artificial neural network and was trained through causal inference with supervision using established maternal cardiovascular risk factors and covariates such as physical findings, symptoms, and medical histories. After working through the dataset to remove patients with limited data, such as those with a single encounter in the EHR, HOPE-CAT analyzed each individual patient's data on an encounter-by-encounter basis to identify risk factors such as elevated blood pressure readings, shortness of breath, and chest pain that may have indicated the development or worsening of cardiovascular conditions during and immediately following a pregnancy. Following analysis, the detection of onset of risk by HOPE-CAT was compared to the corresponding EHR recorded diagnoses in the source data's timeline, essentially comparing when HOPE-CAT had detected signs of risk to when a diagnosis was recorded in a patient's record. Our results show that HOPE-CAT identified factors predicting cardiovascular risk an average of 56.75 days earlier across all patients when compared to a related diagnosis or intervention in the EHR. When findings were further analyzed by diagnosis, on average, signs of preeclampsia were identified 60.2 days earlier, with cardiomyopathy detected 13.9 days earlier, and signs indicating potential thromboembolism detected an average of 15.25 days earlier. One interesting finding to note is that HOPE-CAT was not initially trained to detect signs of organ failure. However, after several patient risk profiles were surfaced by HOPE-CAT that did not have expected diagnosis outcomes in their records, it was discovered HOPE-CAT had identified patients who were showing signs leading to heart, kidney, and/or liver failure. Signs of risk were detected an average of 13.6 days earlier for patients that ultimately experienced heart failure, and 25 days earlier for patients who experienced acute kidney disease or failure. Of the patients within our dataset, 42.7% were Black, 35.7% were white, 4.7% were Hispanic, 3.2% were Asian, 0.4% were American Indian or Alaska Native, and 13.3% were of other or unknown race. 77.6% were between the ages of 20 and 34 years of age, 21.9% were 35 years or older, and 0.6% were aged 20 years or less. In conclusion, We aim to demonstrate that high-risk cardiovascular conditions in pregnancy could be identified earlier than typical discovery by a healthcare provider. This was done by leveraging Invariant's HopeCat machine learning technology, which was trained to surface signals and trends in a patient's medical records, agnostic of factors leading to bias, such as patient race and socioeconomic status. We found that HopeCat provided early identification of cardiovascular risk in a cohort of pregnant women, and these findings support the use of machine learning within electronic health records as clinical decision support tools. Technology combined with providers' skills and knowledge is an effective approach for early identification of cardiovascular risk associated with maternal morbidity and mortality. In addition to demonstrating benefits associated with early identification and intervention, the results of these findings can alleviate stress on medical systems, along with decreasing the risk of morbidity and mortality among pregnant patients.